Hi there everyone, thank you for tuning into my YouTube channel. I'm Anthony. I ruptured my Achilles tendon in early August, and like most of you I look to YouTube and other information sources for advice and guidance on whether I should undergo operative or non-operative surgery. So why did I make a video and why should you watch mine? Well, it appears most of the videos on YouTube seem to be quite old, and most are over 2 years old, and surely medicine and science are bringing new procedures and rehabilitation techniques. I've also found contradictory advice from professionals in the same video which seemed confusing. I wanted to give a UK perspective outlining how the NHS helped me in my journey, and I have lots of time on my hands now that I can't play sports. So why watch mine? As I'm probably one of the oldest at 61, I wanted to recount my journey. As a diabetic, I am able to explain how long my wounds took to heal. I have undertaken considerable research which has influenced my decision and will fast track your own research. I won't use medical jargon, but will use logic, reason and rationale to explain the options. But be careful, this decision is something that you have about 2 weeks to decide following rupture. And if you are serious about returning to competitive sport, continue to watch my video. It might just influence your decision, and give it the thumbs up. I will take you through the steps involved to be able to help you make a decision that is right for you based on getting a diagnosis to confirm full rupture of your Achilles, the advantages and disadvantages of non-surgery and surgery, the commonalities between the two procedures, my own surgery process, and finally my conclusion. This decision is something that you have about 2 weeks to decide following rupture, and if you are serious about returning to competitive sport, continue to watch my video. It might just influence your decision, and give it the thumbs up. So, a little bit about me. I live just outside London in England. I'm a badminton player, off I suppose a reasonable club standard, and I played for the last 40 years. I stopped playing badminton about 12 years ago as my Achilles was troubling me. But then being 3 stone heavier, I started playing again pre-lockdown. I then aggregated my Achilles about 5 months ago and rehabbed it for 2 months. At least that's what I thought. I then ruptured it in early August playing when I fell over. I was able to walk off court but had very heavy swelling, and so unable to tell if it was ruptured fully or partially. If it is a complete rupture, you can walk on it and it will not be as painful as the tendons are not connected. If it's a partial tear, as the tendons are partially connected, walking pulls on them, tearing them and causing pain. So my first port of call was my GP, who conducted a Thompson test to confirm that I had a ruptured Achilles. The process was to make me kneel on the couch with my ankles hanging off and then pinch my calves and watch my toes flex. No movement confirmed the rupture. She said she would book me an MRI scan and a physio appointment. When I asked how long it would take, she said it would take a minimum of 2 weeks. So shock horror, I knew that with these type of injuries, any delay could impact my outcome and my return to sporting activities. She advised me to go to our A&E, our accident emergency, as they would progress matters for me much faster. When we went to A&E, they redid the Thompson test and confirmed the worst. There are other indicators which including searching for and finding a gap in the Achilles. Equally, look at the injured ankle when the hanging of the couch and look for the angle of the dangle of the foot. It will be lower than the good foot. I believe the NHS do not do ultrasound scans at A&E. The x-ray that was taken showed that I had some degeneration of the heel, but luckily no bones broken. The NHS, even without an ultrasound, assume the worst case and treat you for full rupture and put you in a boot with 5 wedges, which puts your ankle in a downward pointing angle about 20 to 30 degrees. Like the Model T Ford car, it only comes in black, I'm afraid. I was given cocodamol and blood thinning injections, and we were out within 2 hours. By email, I received a copy of my discharge letter and a text message with links to the Virtual Fracture Clinic. The Virtual Fracture Clinic is a consultant-led service where referrals are reviewed by both a consultant orthopaedic surgeon and an advanced orthopaedic practitioner within 48 to 72 hours. And once your imaging has been reviewed, and depending on the nature of the injury, you'll have discussions to review options. You also get a patient information sheet with information about the Achilles injury. So well done, NHS. The process was straightforward. However, the big decision still awaited me. Much is said about the type of scans that you can undertake to determine the extent of your injury. I mentioned earlier the 3 basic tests that I initially undertake in diagnosis. However, there are 2 types of scans which can provide you much more information to influence your decision. Ultrasound. This is real-time dynamic structure, providing 2D images of a 3D subject. Best to measure thickness and gap while showing location of rupture. Although some consultants say they cannot read it and is more reliant on the radiographer's skills. It is also the cheapest type of scan. MRI, magnetic resonance imaging. This provides high resolution 3D static images of soft tissues, organs and bones, thereby providing detailed anatomical information and assessment of deeper structures. But it is not dynamic, but consultants find it easier to read. It's good for partial ruptures, degenerative changes, and also to monitor healing. I was lucky I went to the hospital for an MRI scan 3 days later. This I felt gave me the best chance to determine the length of the gap and any other degeneration and how close to the nerve the injury was. Much of this will become clearer later on. I got a call the next day, which was Monday, to come in and speak to the consultant to discuss options. By now I'd read up on the advantages and disadvantages by looking at YouTube and speaking to friends who tore their Achilles previously. For me, badminton is a major part of my life. At my age, if I change to a new sport like tennis or another sport, I'll never progress to a level that I'll enjoy. It's also part of my social life and I want to return to playing. So my consultant said he was okay for me to have surgery, and as I understood the risks, as I was older and a diabetic, so greater chance of wound issues. He was happy for me to have the surgery and said that as the gap was large, more than 5 millimeters, and because of the type of sport I played, he, in addition to stitching the tendons together, would anchor them to the calcaneus, the heel, using 2 screws. More about this procedure later on. So surgery was scheduled within the next 2 days, so I went home and had to wait by the phone. Now for the interesting bit with your options. Clearly there are 2 paths to your journey. You have non-operative, conservative, and operative, which there are 2 types of surgery, as a procedure for recovery. Okay, so let's look at non-operative, also known as conservative treatment first. What are the advantages? Well, if your tendons are close together, there's a better chance that they'll fuse back together, but you'll need an MRI or ultrasound to confirm the gap size. Maybe you could ask your consultant or surgeon what is the gap size. There are no operations, so no wounds and no infection, and so no pain from these 2 sources. Research suggests that you can do early weight bearing and movement much earlier. This healing allows a quicker return to work. However, note that this does not mean a quicker return to sport in any form. What are the disadvantages? Well, you need to be placed in a boot within 48 hours with the wedges in the equinus position. Preference for less active patients where they do not perform at a higher level. Recommendations for comorbidities: if you have diabetes like myself, a heart condition or smokers, you're more likely to have this option. But it doesn't address any clearing of scar tissue or tendons being meshed together or thickened blood. More importantly, the results suggest that there is a 3 to 4 times more chance of re-rupture. Okay, so let's move on to surgery. But did you know there are 2 types? And the one chosen for you will be down to your surgeon's preference for you. There is open repair surgery, where a large opening, i.e. a long cut, is made vertically above the tendon rupture site, so that inner organs or tissues are exposed. Then there is the minimally invasive surgery, percutaneous, where access to inner organs and other tissue is done via needle puncture of the skin, keyhole-like. You will see that even this has multiple ways of stitching back the tendon. Let's look at the advantages common to both types and then delve into each to learn which type may be more suitable over the other. Please understand that a ruptured tendon is made up of collagen strands, and when they break, you do not have a clear tear. If you have broken a bone, this is easier to reattach. Some would say they are like spaghetti, and surgery, especially open surgery, is the only way to look at the extent of the damage and clean up. So what are the advantages? The key one is that achievement of length of restoration is more predictable. It is more reliable for cast strength, recovery, hops, jump tests, heel raise tests, and endurance tests. It's better suited for lifestyles associated with more active patients. And believe it or not, patients will be more compliant with instructions following surgery rather than not having surgery. There is less re-rupture rates, 2.8% for surgery compared to 13% for non-operative. But what are the disadvantages? Well, there's things like nerve injury. With an operation, there's always a small risk of injuring or stretching the surrounding nerves, which can lead to numbness or even weakness. These symptoms mostly resolve in time, but they can persist. Infection. The risk of infection with any foot and ankle operation is up to 5%. The majority are minor infections that can simply be treated with antibiotics. Occasionally, some patients can develop a deeper infection that might require another operation. Delayed wound healing. The blood supply to the skin at the back of the ankle is poor and could cause delayed wound healing. Very occasionally, you may require another operation with a plastic surgeon. Patients who smoke are at much higher risk of this complication. For myself, being a diabetic, it means wounds take longer to heal. But I managed my diabetes well, so had no issues. Chronic or regional pain syndrome. Following surgery, a very small proportion of patients can discover that ankles become indefinitely painful, swollen and sensitive. If you develop this, you may require specialist care from a pain consultant. So let's look at surgery and how it's developed over time. Open repair surgery. Where there's been a delayed diagnosis, normally after 2 weeks, as blood and scar tissue form, this form of repair allows one to examine and sort out the damage. Later surgery techniques should ensure that all knots in the repair are deeply buried and do not lie superficially under the wound closure, as this is a foreign body and will delay your healing. Any nerves can easily be seen and care taken not to cut or damage them. We can close the peritoneum, which is the protective shield around the tendon, in order to relieve tension on the skin closure and minimise wound complications. The other form of surgery is a minimally invasive technique. This is called a percutaneous type of surgery. Because of that high incidence of wound complication of open surgery, percutaneous techniques have been developed to lower the rate of wound infection. Less and smaller holes heal quicker and are less prone to infection. percutaneous and open techniques have similar results, similar return to work rate, re-rupture rate, calf diameter and plantar flexion strength. See later which form of surgery I had. The percutaneous Achilles tendon rupture has a higher risk of sural nerve injury as there is limited visibility. Commonalities between an operative and non-operative option. The timeframes are the same. You spend the same amount of time in a boot and you do similar physio and exercises. Some would say that surgery or non-surgery is not really the key, but rehabilitation is what influences your own outcome. Patient satisfaction and pain were noted to be better in a non-operative group initially, but later favoured the surgical group at a 1-year period. Blood clots, leg or lung. With both these, there is an increased risk of developing a blood clot in the injured leg. You will be individually assessed and may be given blood thinning medication to reduce the risk of developing a blood clot. Re-rupture. There is a small chance that the Achilles tendon repair can fail with a re-rupture. It is extremely important that you follow the post-operative instructions. If at week 5 on conservative treatment you have a fall, it is argued that it is better to stay on the treatment program as the boot will be coming off within a short space of time and an outcome aligned to the damage can then be made. Some hospitals in the UK find that surgery is more expensive than conservative treatment and they make a business case and argue for it that conservative treatment is a better option. Re-rupture out of the boot usually happens between 8 and 12 weeks, where you slip in the bath or the shower, or you might flip up on the stairs. In my research, I've been surprised to see the array of those rupturing their Achilles. These even include those who squat with heavy weights, who I would consider to have super strong legs and Achilles. Even semi-professional footballers and also the likes of David Beckham and NBA players are not exempt. So my exciting day arrived for my surgery. No food, so fasting from midnight, and no drink 4 hours before the operation. For myself as a diabetic, this meant that I had to stop medication, as not even a sip of water to swallow a pill was allowed. As earlier touched upon, because of previous Achilles problems I had, my surgeon decided to use the minimally invasive procedure and perform the speed bridge repair. You will see that a jig is used to thread through the stitches into the upper torn end of the tendon in a horizontal arrangement. Some of these stitches are tied to the upper tendon and the others are then pulled down through the lower torn tendon, and then a swivel lock anchor is used on both sides to anchor the screws to fix them to the calcaneus. I was given a nerve block injection in my ankle to interrupt pain signals and reduce inflammation. It lasts about 12 to 18 hours, after which then you'll have to take other necessary painkillers. My neck also hurt and I had red markings, probably due to the position that they held me during the operation. Some surgeons use absorbable sutures, which dissolve over time, but are more difficult to work with and manipulate. Non-absorbable sutures are easy to tie together and work with, but are considered a foreign item that is left in the body, so may cause infection. The operation lasts between 45 and 90 minutes. I was asleep, so not really sure how long mine took. When you wake up after surgery, I looked down and I was just relieved to see that my right leg was still there. The boot will become your friend over the next 8 weeks. I was fitted with an air-step walker and I was told that I could do partial weight bearing immediately. I was fitted with 3 wedges in my boot. However, there were 5 available, but each person is different in terms of the number they'll need. The air step has air pumps on the side to inflate little bags inside them and aid cushioning, but I found them too harsh for my wound. Before you leave, ask for a spare liner, as they smell, and you'll need to wash them while you wear another. There are two key terms that you'll hear about: dorsiflexion and plantar flexion. Your surgeon and physio will tell you about these and what you need to do and what you don't need to do to improve recovery and prevent damage. The key thing is that you do not want to extend via dorsiflexion the tendon, thereby lengthening it. This will mean that there is slack in the tendon, and when you push off, you'll lose that explosiveness. This is something that's probably needed for things like tennis, for badminton, for basketball. If after rehabilitation you end up with this outcome, the only course is to have surgery to shorten the tendon. Conversely, you can end up with a shortened tendon, which may make certain movements more restrictive, but you need to do appropriate stretching exercises to relieve this. My own research suggests that dorsiflexion exercises that stretch the tendon, thereby lengthening it, should be undertaken at 12 weeks and not 8 weeks. I suppose on your mental state. Fortunately, I'm very strong mentally, but I did reflect on how my life would change. No badminton for 9 to 12 months. Should I change to paddle or tennis? Minimal social activities, not being able to just go out and drive and being reliant on others. If you live on your own, you might find it hard, especially in the first 2 weeks when you spend all your time in bed with raised legs and moving is difficult. My wife was very good at looking after me, so she'll get a wonderful Christmas present. Look at it like this. This is a once-in-a-lifetime opportunity for you. Even when you return to work, you will have the time you spent playing sport, gardening as free time. So learn a new language or do that task that you always put off. Or create a YouTube video that is better than mine. Don't forget to like my video. As I'll be returning to the fastest racket sport, badminton requires explosive movement, playing on your toes, jumping and landing from smashes with fast change of direction. I feel that it will be easily 9 to 12 months before I will feel confident to start playing again. I did a lot of research in putting together this, and 2 videos, YouTube websites that I found that stood out for me. One has an excellent conversation on conservative versus operative management treatment between a surgeon and a physio. The other website, Treat My Achilles, has loads of useful advice. I'll put links below for you to access these YouTube sites. The very subject is a complex one, with surgeons and physios each having their own opinion. The research seems to be outdated, or the studies never seem to be large enough. In summary, it's red apples and green apples. There is a lack of defined, universally accepted outcome measures, as all research bundles the different types of patients, those who are sporty, those who are non-active, into a single cohort. There's also a multitude of different reparative techniques, as you've seen earlier on. And there's also a diverse range of post-operative protocols. So the question is, do I really need an operation? There is no right or wrong answer. It depends on your own individual circumstances. You need to understand the factors which will influence your decision for you, and that it's the right outcome. Your goal really can be summed up as this: ensure for your repair of the tendon that it returns as close to its normal length as possible. Any attempt to avoid making the reconstructing either too short or too long will cause you problems. Most of the videos for conservative management say that at week 4 or 5 they come out for cast and they get an ultrasound to check the status of the healing. What then happens if it's not healing as planned? One poor individual on YouTube on the conservative treatment found out at week 4 after an ultrasound that he had a large gap and nothing could be done about it. He would heal long, as they say, and this meant he would lose any explosive push-off and he would suffer calf heel raise issues. There was nothing that could be done, He should have really been earmarked for surgery at the start. I hope that you've enjoyed watching my journey. As mentioned, I made this video as I felt that it addressed the arguments for surgery and non-surgery, and this was an important topic to share with you. As mentioned, I won't be documenting my rehabilitation journey, as there are great videos from personal trainers and physios that show you how to get from week 6 to month 6, week 24. Should you have any queries about my video, I'll do my best to answer them. I will post at a later date to update on my recovery and compare how and where I am. If you like my story, then do please click on the like button and subscribe button, and I look forward to seeing you again. Take care. Bye bye.